Hello, my name is Yoshi Bauer. Welcome to the My Special Needs Connection webinar and podcast series. As a parent of children with special needs and as a professional advocate, I understand the challenge of connecting parents and professionals with the information that they need to serve children and adults with special needs. At My Special Needs Connection, we empower parents and professionals through valuable instruction and insights of experts in the special needs community. We're excited to come alongside you to provide you with information that you need. Let's grow through the exchange of knowledge and the hope of success. Be sure to subscribe to our newsletter and YouTube channel for new releases. Please enjoy our webinars and podcasts.
My name is Karyn Searcy, and I'm a speech and language pathologist in private practice and teaching at San Diego State University. I have been in the field since the early 70s, and I went to an undergraduate school in Illinois outside of Chicago where we had a clinic, and we were able to, as undergraduate students, work with children and adults with developmental disabilities and or acquired losses or fluency problems. And I was able to find out at a relatively early time in my career whether or not I wanted to pursue this as a profession. My specialty is working with parents in early intervention, and in 2011 I published a book called Early Intervention in Speech and Language Therapy, Empowering Parents. I was really lucky in 2007 to meet autism researchers at Rady's Children's Hospital, SDSU, and UCSD, and we started working in 2007 to develop an earliest identification tool for children at risk for communication and relating disorders, which is now called Project Impact for toddlers, and it's based on a program for older children called Project Impact. We've been doing the research and implementing the program since that time, and we've now been together over 12 years, and we're still doing more research on that. I teach at San Diego State, and I primarily supervise students who are working with children with autism or related disorders, and work with my students on coaching parents and helping parents be part of the process, which is incredibly important to us. The first thing I would tell parents is figure out what your family dynamic is, what's important to you and what's important to your child. We know that early intervention is incredibly important with anything. If a person has a stroke, we need to provide therapy immediately if that's an adult. If somebody has a brain injury from a fall or some sort of accident, we need to get speech and language therapy set up right away, because the ability to communicate with others in your world is incredibly important. And in early intervention, it's so important because if a parent can't communicate with the child, they're going to feel lost, and the child is helpless and guiding them on what they need. So the first things that I look at in terms of avoiding the power struggle is never asking a child to do something we can't help them do. And that includes talking, right? We can't help a child talk, but we can help a child communicate. So I'm a very big proponent of alternative methods of communication to help jumpstart the communication process. And most of the time with babies, I use gestures so the child can learn early on, if I make this gesture, I'm letting my mom know I want a cookie. I really push the importance of not teaching children more, want, or please, because those are overgeneralized terms, and we hear a lot of children walking around saying more, or gesturing more, or please. Those are not specific. I really recommend using very visible verbs and important objects or actions that are important to the child. So if a child doesn't like to take a bath, we wouldn't work on water and bubbles because that's not something the child is wanting. We have to find out what the child wants, and a lot of times parents can't figure that out because the child's not communicating. Most of the time when we talk with parents, we find out a child likes to watch a movie or listen to music, and those become the areas that we're going to target. We're going to do music on or watch movie and make sure that the child can communicate those things. We don't want to do more movie or more music because more will be the one that sticks. And more can be anything. Eat, cracker, or throw ball are going to look very, very different. So we want to make sure that we're targeting specific and explicit language so the child can understand the power of each word. You know, there's a lot of therapists who have their therapy in a box, and they ascribe to a certain strategy or technique. And unfortunately, there's a lot of parents who will call us up and say, do you do this method or do you do that method? And we don't do any one method. We adapt our methods to meet the needs of the child and the family. I've had therapists who get frustrated with that, and I have students who get frustrated by that because they want everything to be black and white. This will work, this won't work. And what I remember as a younger therapist is wishing that we had litmus paper. I could put the paper in a child's mouth, pull it out, and go, so you need to work on this, this, and this, and this is what's going to work for you. It just isn't like that. We, even at San Diego State, when I'm working with my students who have very complex children that they're working with, we can't nail down goals for the semester till we're halfway through the semester because everything's a moving target. And we have to move with those targets, and we have to move with the families and with the child. So there's nothing that's absolute in therapy. And if you have a therapist who is seemingly rigid in her approach and not listening to you as a parent, then I think it's time to ask to see another therapist. And if you're at an agency, most agencies have several therapists, talk to the director. Most directors, like when a parent calls me and says, I just don't think this match is a good fit, I'm thrilled to hear that because then I can work with you to find a better fit. It's not everybody's going to be a good fit. Early intervention in our country, and particularly in our state, is supposed to be in home or in the natural environment. The problem is that's not always feasible. We do, at TERI Crimson Center, we do provide in-home therapy for children under 3, which is typically funded through the coordination of efforts by San Diego Regional Center and insurance companies, or just the San Diego Regional Center. The problem with the in-home is that it isn't the right fit for all families. Sometimes we go in home and the parent needs to take a shower or wants to wash the dishes, and really we want that parent fully participating in the session because we want to coach families on what to do while they are coaching us about their family lifestyle and their child. So we can really, I call it reciprocal coaching, so we can get from them what's important to them and their child, and we can give to them strategies that we want to trial. And collaboratively, we develop a program for their child. The first thing we start with is selecting a vocabulary of important and valuable words and methods of doing that. And again, because we can't make a child or help a child say a word, we can help them ask for a ball, and then we can immediately give them the ball, and then they see the power of the communication. We get asked all the time by families who are concerned that if their child has another form of communication, they won't verbalize, they won't use vocal speech. And some families are resistant to using augmentative communication, like an iPad for with a communication application. Some are afraid to have us use gestures because, oh, if my child can ask for a ball this way, he won't use his words. There's a lot of research in those areas, and the research supports the use of augmentative communication to jumpstart the communication process and have the child learn to be independent in their requesting things and in commenting on things and protesting. I just started working with an in-home child who's about 24 months with a rare disease, and her mother and father are both doctors, and they are wonderful. They really are part of every session I have in home with her. And they were a little reluctant to have me use gestures because they were concerned about her using that instead of using her words. Within 2 weeks, this child has picked up so many gestures. We don't use American Sign Language. We use modified baby sign because these children are not going to be communicating with the deaf or hard of hearing community. We want them to have a way of communicating. And when I use the gestures, I want to make sure that each gesture represents a syllable of the word so we can work on motor planning, because we don't know what the child's ability to use their mouth is going to be. So for instance, we will do 1 movement for ball, 2 movements for cracker, and 3 movements for butterfly. And I learned that from a child about 15 years ago when I saw him look at his hand and do I. And I thought, oh, that really is helping him motor plan and using syllabication for each of the words. So we're using that technique. This mother of the child that I'm working with in home now said to me yesterday she's so happy that we did the gestures because she didn't know how much her child understood. And we found out from a very early point that this child understands virtually everything, but she has no form of verbal communication. She's not even vocalizing that much yet. So having her request a ball or bubbles frequently, or we're doing turn page for a book, she's really taking off on this. So now this is another thing I had never thought of before the mother pointed it out to me yesterday, that her child is now letting her know how much knowledge she actually has. And had we not been doing the gestures, we wouldn't know that. That's another point that I want to make, is having been in the field for over 40 years, I still learn something new virtually every day. Years ago, I met a therapist and I said, isn't it odd? It doesn't matter how many years of experience you have, you still can walk into a therapy session and have no idea what to do, because every child is different and every family dynamic is different. And this therapist's response to me was, I've never had that happen. I always know what to do. I don't think you should be seeing a therapist who can say that, because I should be as confused about your child as you are until we start working together. And then we can form this collaboration that's going to help your child express himself. There's lots of things that have changed over the years. The one big standout thing is the diagnosis of autism. Back in the early 70s, we had autism spectrum disorder, and it was very specific, and there were very few people that fell into that category. By 99, it was exploding, so we're having a higher prevalence, and there really is more children. There really are more children with overall developmental disabilities, and specifically with autism. But back in the 70s, we were diagnosing a lot of children with what we called developmental aphasia, which meant they were having trouble with word retrieval and sentence construction. And it's hard to know what comes first. Is it an inability or limited ability to communicate that impacts your socialization, or is it your dislike of socialization that decreases your ability to access language or your desire to access language. So we're not really sure. But now we have autism spectrum disorder, which is huge. And children at one end of the spectrum don't look like the children at the other end, and they don't have the same needs. That doesn't mean one is higher than functioning than another. It's more of a lateral comparison. And children who are at one end of the spectrum have different needs than the children at the other end. And then the children in the middle have more similarities. I'm asked frequently why there's such an increase in the prevalence of autism and autism-related disorders. And it's an interesting question that I don't really have an answer to. I think it's a combination of things. I think there are environmental influences because we're seeing that there's more neurological things going on with children who are diagnosed with autism. We're seeing more siblings diagnosed with autism, suggesting there is a genetic component, and there's a lot of research supporting the genetic argument. I know that it's a really hot topic to talk about whether it's pharmaceutical influences. I just know that there has been, in addition to better diagnostic methods, which we definitely have because we can diagnose children or recognize children in need at a much earlier age than we used to. Like I said, we used to think 5 was early start, and now we're trying to get in there by 12 months or before. So there is better testing, and I think there's just more and more children diagnosed with and having developmental disabilities because speech and language therapists are at a shortage now. At San Diego State, there are over 500 applicants for graduate school, and we don't have, I don't think, more than 48 positions for graduate students. So across the nation, there's more need for speech and language therapy. I want to touch on another topic, which just came to my mind, which is why we do early intervention, because we still have a lot of families who think their children are too young and they will develop if we just give them time. And it's true, there are some children who are what we call late talkers, and by the time they're 3, they'll just start talking. But by the time they're 3, the parent-child relationship has already gotten distorted because we've had 3 years of a parent not being able to communicate with the child and a child not being able to efficiently communicate with the parent. So by the time the child's talking at age 3, there's already something that's been damaged, and we can't repair that. We can't change the trajectory of that development. So we'd like to get in there early and work with the parents, which is why I like parents to be advocates at the school level, but also in early intervention. They need to be part of that change. They need to be an active participant in that process. And I was just at a rare disease conference over the weekend, and I've had parents still telling me that they're not allowed to participate in the speech and language sessions. And I said, you need to advocate to get in there, particularly private. It's true in a school district, you're probably not going to be able to be part of that process, but you can reach out to the speech and language therapist anytime, email, call, whatever. And if the therapist is not responsive, ask for the case manager and say, I really need to know what's happening. But if you're going to private therapy, absolutely parents should be part of that process. When I first developed Crimson Center, I made sure that all of our therapy rooms had observation rooms because my plan was I wanted parents to either participate directly in the sessions or observe so they would know what's happening. And they could tell us, that's not working, I don't like when my child's doing that, or this is really working, I'm going to do this at home. But then I found out that families were bringing books into the observation room because they wanted to read, or a magazine. And what I realized over time is that the parents also need a break. So we need to have that balance. I require that my therapists bring their parents into the last 5 minutes of each therapy session and build on that. So the parents can have a positive interaction with their child and work on something that's already getting established, but we need to stabilize it and make sure it's generalized outside of the clinic setting. In 2005, we conducted interviews with parents who had finished the early start process and their children were moving into transitioning through the school districts. And we asked them to reflect back on what it was like for them during the early start process, which is the most stressful. And I teach a program called Ambiguous Loss, working with parents during stressful times. And that's what is it that the parents really need from us. And it's based all on these interviews and the videos that I show of the parents talking to providers. We asked them, if you could speak to a provider, what would you like to tell them? And the parents were amazing. They were very articulate. And of course, we were able to edit out a lot of stuff so we could get to their points. I think it taught me so much about how important it is to work with the entire family. And at an early time in my career, because I couldn't afford marketing, I would volunteer my time at a lot of resource fairs. And through that, I got to participate in a lot of the marches that happen around San Diego County and some of the other activities. And I got to know families outside of the clinical walls. And I think that really has enlightened me more than anything, which is why back in 2011, I brought out the I Can Bike program, which teaches the children with developmental disabilities to ride independently. And the best part of that program to me is when parents leave the program and continue to practice riding bicycles with their children. And then I get a video from Sequoia with the parents saying, this is the first time our daughter's been able to take a bike ride with us as a family. And that's going to promote communication anyway, but it's such a huge piece of what's missing and what we can provide. And always remembering that the families may be educated in areas that we're not, and they're educated in their family, but they didn't choose to be in the world of special education, and we need to help it be a comforting place for them.